Hello. I'd like to spend a few minutes with you today to explain a little about this baffling disorder called CIDP. I hope it will calm some of your fears and help you to better understand what might be happening. First, let's review the anatomy. Peripheral nerves connect the brain and spinal cord with the arms and legs. They carry impulses that cause muscles to contract and relay sensations such as pain, hot, and cold back to the brain. Damage to these nerves produces weakness, muscle wasting, poor balance, and numbness. Some of the causes of nerve damage include trauma, pressure on nerves, blood vessel blockage, and inflammation. Chronic inflammatory demyelinating polyneuropathy, or CIDP for short, is one of the treatable disorders caused by peripheral nerve inflammation. If left untreated, it results in progressive loss of strength in the legs and arms. Though more people develop CIDP when they're between the ages of 50 and 60 than at any other time, people of all ages can get this disorder, from children to the elderly. It affects men twice as often as women. The number of new cases of CIDP that occur each year in the United States and throughout the world is small. Only 1.5 to 3.5 people per million get CIDP. CIDP can extend over many years and even decades. At any one time, between 5,000 and 9,000 people in the United States are affected by it. A patient with CIDP will usually report loss of strength and sensation equally in both arms and legs. In the beginning, symptoms progress steadily for at least 2 months. Slow development of symptoms sets CIDP apart from other inflammatory conditions of peripheral nerves, such as Guillain-Barré Syndrome, also known as GBS. This is an important difference, since many patients are mistakenly told they have GBS or chronic GBS. This confusion may lead to delayed or incorrect treatment. GBS patients get weak rapidly, within 1 to 4 weeks. During the recovery that follows, most patients with Guillain-Barré syndrome walk without help within 3 months. Unlike Guillain-Barré syndrome, CIDP does not automatically go away. Although patients in the past could, over time, become very weak to the point where they required a wheelchair, currently available treatment ensures that 90% of patients are able to walk without aid and enjoy an active life. CIDP develops differently in individual patients. Some forms progress gradually over several years. Others consist of multiple episodes that may be separated by months or even years. A third type is more limited and extends from 1 to perhaps 3 years. The factors that cause patients to develop CIDP, as opposed to the more limited course of GBS, are not known. Some investigators suspect that certain patients may inherit a gene that makes them more at risk to develop CIDP, but at this time there's no strong evidence to support this theory. Rarely, CIDP can affect more than one family member, brothers or sisters, or a parent and child, but it does not normally occur in later generations. The way in which the nerve is damaged in CIDP is not fully understood. Most evidence suggests that this is a condition caused by our own immune system. Each of our bodies has an immune system that includes antibodies and white blood cells. It normally fights off viruses and other infections. In some disorders, the immune system, by mistake, reacts against parts of our bodies, causing disease. This may be the case with CIDP. With CIDP, drugs that regulate a patient's immune system can be used to treat and prevent peripheral nerve damage in CIDP patients. This is a representation of a healthy peripheral nerve. As you can see, it's a bundle of nerve fibers. In the single fiber shown here as an axon, there's a casing or sheath covering the fibers. This fat-rich tissue called myelin is produced by a special cell called a Schwann cell. Myelin works like insulating material that wraps around an electrical wire. If it's stripped, it can cause the wire to short out. In the nerve of CIDP patients, the myelin surrounding the motor and sensory nerves is attacked by invading white blood cells called macrophages and stripped from the nerve. This loss of myelin makes it impossible for the nerve to conduct electrical messages from the brain and is the reason patients can become weak. In patients with prolonged or severe cases, the nerve fiber or axon can be damaged. During CIDP, the peripheral nerve continually repairs itself, regrowing damaged nerve fibers and replacing the myelin. This repair process may be slower with older people than with younger people, causing them to have a poorer recovery. Treatment can prevent this damage, allowing patients to return to an active and productive life. Over time, with repeated episodes of myelin damage and attempted repair, Layers of the Schwann and other cells produce a swelling around the nerve fiber called an onion bulb that further limits the nerve's ability to function. Prompt diagnosis and treatment of CIDP is important because patients respond more completely to therapy when this condition is caught and treated early. Unfortunately, we do not have a specific test to diagnose this disorder. Diagnosis is best made by a neurologist, a physician that treats disorders of the brain and peripheral nerves. The diagnosis is based on the patient's clinical history, a physical examination, and by the results of supporting studies. These supporting studies include nerve conduction studies and, in some cases, a spinal fluid examination. Samples of the patient's blood may be taken to rule out conditions such as diabetes, toxin exposure, and inflammatory disease of blood vessels that cause nerve damage and may look similar to CIDP. Rarely, a nerve biopsy may be done to either confirm the diagnosis of CIDP or rule out another disease. Symptoms of CIDP may vary. Most patients complain of difficulty climbing stairs or lifting their arms up to carry a bag of groceries, shave, or blow dry their hair. These symptoms indicate muscle weakness. Other symptoms reflecting sensory nerve damage include a loss of balance, numbness in the feet or hands, or pain. A neurologist's examination can confirm that these problems reflect peripheral nerve damage and not damage to the brain or spinal cord. Some of these symptoms and their onset are demonstrated by the following two patients. Our first patient is Jane Smith. She's a 34-year-old woman who works as an administrative assistant. She's an avid runner and has been physically active all of her life. I understand from your primary care doctor that you're having some symptoms in your hands and legs. When did you first notice a problem?
Well, I was just fine until about 2 months ago. Actually, we were watching television, my husband and I, and after dinner, I started feeling this tingly feeling in my big toes.
Was this feeling there all the time?
No, the tingling wasn't there all the time, but after about a week or so, it was there all the time, and it began to spread up my leg to my knees.
How long did that take to happen?
About 3 weeks.
Okay. Did you notice any problem with walking or keeping your balance?
Oh, yeah. At first I think I felt just a little unsteady, but then it got worse. I can't even wear heels because I'm so wobbly. I've started to wear running shoes, even to work.
Were you able to continue jogging?
No. My balance really it's just not good enough. And I tire very, very quickly. Plus, I have cramps in my legs. So I stopped running about 2 weeks ago.
Do you think your legs are weak?
Yes, absolutely. Last week, I had to hold on to the railing to climb up the stairs. And even then, I kept catching my toes on the edge of the step.
Okay. Did you have to use your arms to get out of a chair?
Yes.
And did you notice anything else?
Oh, yeah. My feet have started to burn at night in bed. And the pain is so bad, it keeps me up. I can't get to sleep. And I have this sharp pain in the sole of my foot that shoots up my leg. And my fingers started to tingle. I have a desk job, and I use a computer. Because of the numbness and tingling in my fingers, I can't type on the keyboard without looking at my hands. My boss noticed I was having some difficulty, and he suggested I should see a doctor, who then referred me to a neurologist.
On examination by the neurologist, Ms. Smith was found to have weakness in both of her thighs and feet. The reflexes at her knees and ankles were gone. She did not feel a pinprick in her feet, or a light touch up to the mid-calf level. She did not feel vibration in her feet, and with her eyes closed, did not know whether her great toe had been moved up or down. This next patient is a retired 69-year-old man who had been in good health all his life. He went to see a doctor when he had difficulty walking. When did you first notice that something was wrong?
I guess about 5 months ago, I started not being able to feel anything in both my hands. They felt numb for a while, and then the numbness would go away. And I use a computer a lot, so I figured, what do I got? I got carpal tunnel syndrome, something like that. So I went to see my doctor, and that's when he diagnosed carpal tunnel syndrome. He told me this was a common disorder in which the nerves in the wrist got compressed. But a month later, I felt the same thing going on in my feet. And then after another month, the numbness was gradually spreading up from my feet up my legs, and from my arms also.
Did you notice any weakness?
I did. I guess after about 3 months, I started feeling weak. I couldn't even climb the stairs without holding onto the banister. I couldn't walk up a small hill. I mean, on level ground, I'd be okay. If I took my time, walk slowly, I could still walk maybe 12 blocks. Then, about 2 or 3 months ago, I started to have problems with my balance. I staggered. I fell down a couple of times. Once on the stairs, once in the shower. If I close my eyes in the shower, I'm afraid I'm going to lose my balance if I'm not holding on to the rails. My wife started yelling at me. She insists I use a cane to walk with. She's afraid I'm going to fall down.
Okay. Was there any weakness in your hands?
Yeah, about 2 months ago. I noticed my hand grip was getting weak, and I started having electric shocks in my right hand, all the way up here to the elbow. I've also been dropping things. I don't know, my hands just kind of give out. I can't even hold the damn razor when I'm shaving myself, or hold a toothbrush or a pen. I mean, my wife now has to write all the checks to pay our bills. It's really awful. My hands, when I reach out for something, they start to shake. You know what it's like to try to hold a cup of coffee when your hands are shaking? Spilled it all over my pants. I make a mess. Doc, I feel helpless. My wife has to cut my meat for me. My hands shake too much. I choke sometimes when I'm eating. I have to cough a lot. Doctor, it's...
Have you lost any weight?
Oh, yes. I lost, must be 15 pounds over the last 2 months, and I wasn't even on a damn diet.
Okay. Anything else that you've noticed?
No. Yes. I have a numb feeling sometimes on the left side of my mouth, right here, down the cheek. And my voice has gotten lower. Very strange stuff. My voice is lower. I mean, I'm not really hoarse, but it's definitely lower. And I guess when I get tired towards the end of the day, my speech gets slurry. My words sound a little slurred.
On examination by the neurologist, Mr. Brown had weakness on both sides of his face and could not whistle. He did not feel a pinprick on the lower left side of his face. When a tongue depressor was put on the back of his throat, he did not gag. He had wasting of muscles in his feet, a loss of strength in his hand grip, in bending his elbow, in lifting his leg at the hip, and in raising his foot up at the ankle. Deep tendon reflexes at the knees and ankles were absent. He also could not feel a pinprick or light touch in his feet up to the mid-thigh, and in the fingers and palms of his hands. With his eyes closed, he had difficulty telling whether his toe had been moved either up or down, and if standing with his eyes closed, he fell. Both of these patients have symptoms that might indicate CIDP. One is more severe than the other. Both patients had a gradual onset of disease that occurred over 2 months or more. Both had symmetrical weakness and sensory loss in the legs and arms, and loss of tendon reflexes in the arms and legs. Besides CIDP, there are other chronic inflammatory neuropathies, such as Multifocal Motor Neuropathy, MMN, and a multifocal motor and sensory neuropathy called the Lewis-Sumner syndrome. These neuropathies are different than CIDP. The patient's symptoms are not symmetrical. They involve a leg or arm on one side of the body. For example, a patient may have a bad foot drop on one side of their body, while the other foot is almost normal. In MMN, symptoms are limited to muscle weakness without sensory loss. It's important to distinguish these disorders from CIDP, since they may require different therapies. Sometimes it's difficult to make an initial diagnosis. After taking a history and conducting a physical examination, one of the most important tests that helps to make a diagnosis of CIDP is a nerve conduction study. This study measures the ability of nerves to transmit an electrical signal. Trained neurologists or technicians under the supervision of a physician perform this test. To obtain the most information, at least 3 different motor nerves in the limbs are directly stimulated by a brief electrical impulse in 2 or more places along the path of each nerve. Stimulation of the nerve is detected by contraction of a muscle that's controlled by that nerve, and the contraction of the muscle is measured with electrodes applied to the surface of the muscle. If there's significant myelin loss in the nerve, as happens in CIDP, the ability of the nerve to transmit the electrical impulse is either slowed or blocked. In addition to the nerve conduction study, the examiner may use a thin needle placed into a poorly functioning or weak muscle to look for evidence of muscle fibers that are no longer controlled by the nerve as a measure of nerve damage. Spinal fluid examination can also be helpful in supporting the diagnosis of CIDP. Spinal fluid from CIDP patients frequently shows increased protein content, but no significant numbers of white blood cells. The presence of large numbers of white blood cells could indicate that infection or other diseases are causing the patient's symptoms. Samples of blood are studied to look for other diseases that can also cause nerve damage. Nerve biopsies are usually not required, but may be recommended in cases where the diagnosis of CIDP is in question and other disorders may be suspected. Many CIDP patients respond well to treatment that impacts the inflammation in the nerves. Treatments shown to work in clinical trials include prescribing corticosteroids, blood plasma exchange or plasmapheresis, and intravenous immunoglobulin or IVIG. All 3 treatments are highly effective, leading to improved strength and function in CIDP patients. Each has its advantages and some disadvantages that you should talk about with your physician. A steroid such as prednisone can be taken by mouth and given in doses that decrease over time. This treatment is effective and inexpensive. It can result in better muscle strength, improved coordination, speed, and strength of the signal being transmitted by nerve fibers. Side effects of treatment are usually mild and include irritability and weight gain. Less frequently, some patients may become depressed, experience elevated blood sugar, osteoporosis, and high blood pressure. Side effects are reduced by use of the smallest possible steroid dose that is effective in each patient. Additional drugs may be used to further decrease the steroid dose. Such agents include azathioprine and mycophenolate mofetil, among others. Plasmapheresis is a procedure that removes plasma from the blood and replaces it with a new fluid. This procedure is done through a rigid tube or catheter that is inserted into a large vein in the neck or under the collarbone. At first, the procedure is repeated 5 times every other day over a 10-day period. Plasma exchange is safe when done by an experienced center and causes rapid improvement in many patients. If the procedure is not repeated, the benefit is lost, usually within 3 to 4 weeks. Rare complications during exchange can include abnormal heartbeat, salt imbalances in the blood, low blood calcium, red blood cell damage, infection, and bleeding. Because the use of this treatment is limited by the need for repeated catheter placement, most patients over time will require other treatments to manage their condition. Intravenous immunoglobulin, IVIG, is a sterile solution of concentrated, highly purified antibodies taken from several thousand healthy people and put straight into a vein of the patient. The first dose is given through a medium-sized vein in the forearm over 5 days in equal daily doses. Due to the safety of IVIG, it's usually given in an outpatient clinic or at home by an infusion service. The response of the patient may be seen as early as 3 to 5 days after starting the infusions. Improvement can continue over 3 to 6 weeks. Like plasma exchange, the improvement may be lost unless the patient is retreated. A positive clinical response can be frequently maintained with IVIG given repeatedly each month. IVIG is well tolerated, and the IVIG preparations available today are safe without risk of viral infection. Most common side effects reflect the IVIG infusion rate and occur at the time or immediately after the infusion. These include headache, muscle aches, fever, chills, rapid heartbeat, and high blood pressure. This type of side effect can be avoided by slowing the infusion rate or by giving aspirin, Tylenol, methylprednisolone, or Benadryl prior to the treatment. very rarely, serious side effects can occur in patients with a prior history of kidney disease, stroke, or heart attack. Other drugs that decrease immune function or inflammation are used in the treatment of CIDP. The use of these drugs is supported by the experience of individual physicians treating patients who have failed one or more of the primary treatments that we've just talked about, or patients that have side effects from primary treatments. Some of these many drugs include cyclophosphamide, cyclosporin, tacrolimus, mycophenolate mofetil, azathioprine, and rituximab. Use of these agents requires a discussion of the risks and potential benefits with a neurologist experienced in their use. Both of the patients you met earlier were treated successfully, although differently. Ms. Smith has been on corticosteroids for the last 3 months. How are you doing?
At this point, I feel almost back to normal. I still have some tingling in my toes, but I no longer feel out of balance, and I've begun to run again. Not as long as I used to, but I run maybe twice a week for about a mile.
Are you getting any cramps?
No. That seems to be gone.
I see that you've gained weight.
Yes. 15 pounds. My face is fuller. And none of my clothes fit. My husband complains that I'm irritable.
Yeah, all of these may have been caused by the dose of steroids given to control your CIDP.
Is there any alternative?
Well, within the next several months, your doctor will be decreasing the dose of steroids, and many of these symptoms will begin to resolve. Other things can be done that will reduce your dependence on this medication. You can be started on other drugs that will allow your doctor to more rapidly decrease the amount of prednisone you take. Some of these drugs include azathioprine, even a cancer chemotherapy drug, cyclophosphamide. At this point, what I would suggest is you try to decrease your steroids slowly, control your diet, and keep up with the exercise. Our second patient, Mr. Brown, was weaker and had symptoms lasting longer than Ms. Smith's. He was put on IVIG, or intravenous immunoglobulin, and has been on this treatment for 3 months. Mr. Brown, how are you doing?
Just great, really great.
How long is it since your last infusion?
2 weeks.
Okay, well, I know that you have to come a distance. Are you having any trouble getting to the clinic each month?
No, my wife doesn't work anymore, so she brings me in each month. Now, the first month it was a little difficult since I came in 4 days in a row. But now I only come in 2 days a month, and we're talking about whether we can reduce that to 1 day a month.
Has the immunoglobulin helped you?
Oh boy, no question about that. Within a week of starting, I was able to walk without my cane. Now, I wasn't perfect, but I could swallow, and I was clearly stronger.
How long did the effect last? Did your symptoms recur?
Yeah, they did recur. In the beginning, I would start to get weaker 3 weeks after the infusion.
Well, has this changed as you received your monthly treatments?
Oh, yeah. Now I do not always have increased problems before my next infusion. Now that's the reason we're talking about either decreasing the amount of IVIG each month or increasing the time between infusions.
Well, there is an alternative. The IVIG dose could be decreased by either adding a small dose of steroids or by adding some medications that would depress the immune system.
I tell you, I'm very happy with IVIG. I would rather reduce the dose as long as I don't get worse.
Therapy in CIDP patients needs to be tailored to each individual. Some patients, because they have diabetes, may not be able to tolerate steroids, since steroids make diabetes worse. Other patients with kidney disease may not be able to use IVIG. Younger patients may not want to take some immune-regulating drugs, since they may increase the risk of cancer and sterility. All of these issues need to be discussed with your doctor prior to starting on therapy. CIDP is increasingly recognized as a cause of chronic progressive neuropathy. Most CIDP patients respond well to therapy that can limit the damage to the peripheral nerves, allowing them to return to normal activities and lifestyle. Thank you for allowing us to spend this time with you. I hope this video has taken the mystery out of CIDP and that it's deepened your understanding of it. You'll now be able to speak to your doctor, your family, and your friends more productively. If you need additional support, call the GBS-CIDP Foundation International at 610-667-0131 or go to their website at www.gbsfi.com.